Good evening, everyone. Welcome to Ask Your Mentor program, the second session, which is organized by AOMSI Tamil Nadu and Puducherry branch. Today's topics are really important. These topics are surgical principle and minor oral surgery. Mentors for these sessions are Dr. Lata Rao for surgical principles and Dr. Ashok Ramadurai for minor oral surgery. The moderator for the session is Dr. Ritvi Bagaria. Dr. Ritvi is a fellow of the International Board for the Certification of Specialists in Oral and Maxillofacial Surgery. She has also completed her fellowship in oral oncosurgery. Dr. Ritvi has completed her undergraduation and post-graduation from SRMC Chennai. She is currently working as a fellow at Meenakshi Cleft and Radiofacial Center. We welcome you, Dr. Ritvi. May I now request Dr. Ritvi to introduce the mentors and start the program.
Thank you, Dr. Kalpa. So our first speaker for the day is Dr. Lata P. Rao. She is going to give her talk on surgical principles. Dr. Lata completed her BDS and her MDS from Government Dental College, Trivandrum. She then worked for a majority of her career at Amrita Institute of Medical Sciences, Kochi, between 2003 and 2014. Thereafter, Madam is currently a consultant at Aster Medicity, Kochi. She is a fellow of the International Board of Maxillofacial Surgery. She is also the fellow of International Board of Oral and Maxillofacial Surgery and holds a degree in MOMS RCS Edinburgh and MFTS RCPS Glasgow. We welcome you for your session, ma'am.
Thank you. Shall I start? Hello. Yeah, may I start?
Yes,
yeah, please. Yeah.
So at the outset, let me thank office bearers of AOMSI Tamil Nadu and Puducherry for giving me this opportunity. And let me go to my topic directly. The question which I obtained, first question that obtained was what is the difference between monopolar and bipolar cautery? These are my references. The electrosurgery works on the principle of cutting or coagulating tissues by the current that passes through the tissue. As we all know, there are monopolar electrosurgery and bipolar electrosurgery. Both principles of monopolar and bipolar can be understood from this single picture. The monopolar cauterization involves an active electrode which passes from the machine to the patient, and then a dispersive electrode in terms of a plate carries the return electricity from the patient to the machine. Whereas in bipolar cautery, it is the tip of the two forceps, two tips of the forceps is where the current passes, and the current passes only through the tissue that is grasped in the bipolar forceps. So when you are asked about the difference between the monopolar and bipolar, like we have already said, the current passes through the patient via the body in the monopolar, whereas only the tissue grasped between the blade carries the current. The current density is greatest in the active electrode, that is at the monopolar, and it cuts the tissue. Whereas in the bipolar forceps, you can do only the coagulation. And you don't need a dispersive pad in the bipolar cautery. The tissue effects, like if you need a cut, the constant waveform is required at a low voltage to get a cutting effect with the cautery. Where you blend the cutting and the waveforms, then it becomes a coagulation mode. It is very clear from this diagram. When the electricity is in a constant waveform, you get a beautiful cut. And if the forceps is held at a distance, that is vulgarization of the tissue. But when it is at a bipolar level or coagulation level, this is what happens. It's a pure cut. So you use a blend and then you coagulate. So I hope the difference between the monopolar and bipolar is clear. Moving on to the second question.
Thank you so much, ma'am, for that excellent start. Yeah. So I'll just read out your second question for you. So the question was, what are the principles of flap design and the different types of flaps that are used in minor oral surgery?
Yeah. When you think about flap design, what is most important about the flap? You have to have visibility and access to the surgical site. And as we all know, the base of the flap should be wider than the apex so that the blood supply is unhindered to the apical portion. And you should have a firm grip on your instrument, that is a scalpel. It is usually held in a pen grasp, and a single stroke cutting through the mucosa and the mucoperiosteum will prevent rugged edges and delay in healing. And when you have to give a crevicular incision, the blade is held perpendicular in the crevice and given the incision. You have to always keep in mind that the incision line, that is after closure, the suture should lie on sound bone and not on blood clot, which will lead to breakdown of the wound. And the flap elevation should be very careful, and you should prevent buttonholing, which will prevent the blood supply to the apical portion of the flap. And closure is also very important. It should be tension free, and you should avoid pulling the tissues too close, thereby obliterating the sulcus. If you do that, there will be difficulty in prosthetic rehabilitation. Coming to the various flap designs that we use, there is trapezoidal flap. Here also you can see the base is wider, and it gives adequate support or adequate access to the roots for various procedures, and you can get more than 2 teeth access. But one disadvantage will be the gingival recession that is commonly seen with the trapezoidal flap. So easy to remember, trapezoidal part incision contains a horizontal part and 2 vertical releasing incisions. Coming to the triangular flap, there is 1 horizontal part and 1 vertical part of the incision. It is an L-shaped flap, and it can be easily modified. If you want more access, you can put more crevicular incision and extend the flap. But disadvantage is there will be a lot of pressure or pull on the flap when you retract it. So you have to be very careful not to tear the flap. Envelope flap with no vertical releasing incisions, only crevicular incision will give you envelope flap. But it gives very difficult, it's very difficult to reflect and gives limited exposure. Then the semilunar flap is a very small flap, and the lower part should be about 0.5 centimeter away from the gingival margin. But main disadvantage is the incision line lies directly over the bony defect. But the advantage is there is no gingival recession and there is no periodontal tissue problem. And then the other flaps like Y flap or X-shaped flaps can be used, especially in the palatal region for accessing tori. And one simple slide for flap designs in the third molar region. The incisions being ward incision or modified ward incision, as we all know, the ward incision or modified extended ward incision gives triangular flap. But you can use envelope flap also to access the third molars.
Thank you, ma'am. That was an extensive explanation for flaps in minor oral surgery. The next question is, what are Langer's lines, Krasel's lines, and relaxed skin tension lines, and their significance in planning extraoral incisions?
Yeah. When you hear about all these lines, what is it that comes to your mind? The pictures, definitely yes. These are the lines along which the skin tends to age and the wrinkle lines start. Langer's lines were the first described by Langer. He did extensive cadaveric studies and found out certain direction in which puncture wounds will propagate if it is made along these lines. So he came out with the proposition that incisions in the direction along these lines will gape less. But when you compare the Langer lines with resting skin tension lines, in certain areas like the lateral orbital rim, scalp, temporal region, and in the corner of the mouth, the Langer's lines are at right angle to the resting skin tension lines. So what are relaxed skin tension lines? These are not a visible feature on the skin. They are noted by pinching up of tissues in a relaxed state. And it is greatly influenced by the underlying bone or muscle bulk. And incision perpendicular to these lines will result in a widened scar. So you have to always keep in mind to put your incisions along the lines. These are the persons who came up with the explanation for the relaxed tension lines, Bolger. And in the living phase, these lines may sometimes coincide with wrinkle lines. Coming to creasel lines, it was a photographic study of aged faces, and he found out that these lines are formed by movements, and these are more evident during smiling. And he also proposed that cutting parallel to these lines will give lesser scars. So 3 lines you have to remember. There are umpteen number of classification for these lines, but Langer's lines, creasel's lines, and resting skin tension lines are the important ones. But you have to bear in mind that Langer's lines are based on studies done in cadavers. This is how the resting skin lines and the creasel's line differ. In these regions, they are different. Yeah. Ritvi? Yeah, the 4th question.
Ma'am, I'm not able to see your screen.
Oh, okay. Yes.
If you can just
I
move to the next
Is
one.
there any problem with others to see my screen?
Ma'am, we cannot see the question. We can still see the
image
lines.
Okay.
This next slide, if you can change.
No, her screen is frozen.
Oh, my screen is frozen.
Yeah, screen is frozen.
Okay.
And you can, stop sharing and
stop share and then redo it again.
Yes, ma'am.
Let me try that. Is it okay now?
It hasn't come up yet, ma'am.
It hasn't come up yet. I've stopped sharing.
Yeah, I guess now if you start sharing, it should be all right. Yes.
Okay. Can you see?
It has started. Yes, ma'am.
Yeah. The 4th
Yes,
question you can see,
good to
right?
go.
Yeah.
Yes, ma'am. So the next question, ma'am, is on the different types of drains that are commonly used in maxillofacial surgery.
Yeah. We all know what are the indications for drains. It is to prevent collection of fluids or air in dead spaces or to irrigate a cavity. The types of drains are different. There are open versus closed drains, active versus passive, and elastics and rubber drains. When you put a gauze drain or a glove drain, it becomes an open drain, and the collection is collected on a gauze pad, which is kept on top of the drain. Whereas tubes will contribute to the closed drain. And if the tubes are attached to a vacuum device, it becomes an active device. So gauze drains, simple rubber drains, Foley's catheter, especially is a tube drain which can be inserted and with the multiple holes inside kept placed on the tube, is an excellent device to irrigate a cavity. Then red rubber French catheters, we know it is useful for irrigation postoperatively. And then the rubber dam material can be used, and lattice bends. And we all are familiar with suction drains, which is a form of active drain. The difference between the active drain and the passive drains being the fluid recollection is unlikely in active system because of the negative pressure will approximate the tissues, will hold the tissues together. But in passive drain, there will be continued weeping of the fluid, either as exudate or blood. And it is easier to perform a radiographic study with the vacuum drain because they have radiopaque lines on that. And you don't need a bulky dressing on the tube in case of active drain. You can close the wound over the suction drain. But in open drains, you have to have a bulky pad to cover it, to collect the fluid that comes out. Yeah. Ritvik, again,
Yes.
stop. Yeah.
So the next question is on the various modalities and materials for achieving local hemostasis.
So how do we achieve hemostasis? During surgery, we know by pressure or cauterization, or there are thermal techniques. But when you apply local hemostasis, most of the time it is by chemical methods. You have mechanical or passive agents which provide hemostasis status, namely collagen or gelatins. We know gel form or Surgicel, etc. Then there are active agents which provide topical thrombin or fibrinogen products. And then there are flowable agents which act as glues to close a wound. So when you see topical active agents like fibrin-based or thrombin-based agents, they are almost always helpful in cases where there is a congenital defect or acquired defect in the bleeding coagulation mechanism. When the coagulation pathway is defective, then these products become useful. The second group, which we commonly use, the topical mechanical hemostats agents like Surgicels or that is oxidized cellulose or gelatin-based gel forms, they need a functioning coagulation pathway, and they give hemostasis by mechanically forming a clot. Then there are synthetic agents like cyanacrylates, which is a glue. And then there are external hemostatic dressings, which will provide these agents, which will deliver these agents to the local wound. So just a slide on Surgicel. It is a cellulose carbohydrate which is being oxidized. It forms a gelatinous mass when it comes in contact with blood. And it may have antimicrobial properties because of its low pH. The main advantage is it does not interfere with wound healing.
Ma'am, so the next question is on the various types of surgical needles used.
The most important part of any surgery is closure, and you get needles of various sizes and shapes. The needles can be eyed needle, which are considered as traumatic needles, and swaged needles, which are atraumatic. It has a body, it has a point, and it has an end to which the thread is either threaded or swaged on. You need to have a grasp on the needle about 2/3 the distance from the tip, not too close to the end where the thread is present, or not too close to the tip. You can see the maximum contact with the needle holder is with an oval shape of the needle, not the round and not the triangular cut sections. In the oral cavity, the suture needle should be a small half circle or 3/8 of a circle needle. And this circular shape is very important in the oral cavity because it's a limited space and you need to have an arc of rotation. You can give an arc of rotation with your rotation of the wrist to pass the needle easily. Like I said, the various uses of various shapes of the needle, the 1/4 needle, 3/8 needle, etc. And you can see the 3/8 and the half circle needles are commonly used in the gastrointestinal tract and oral cavity. And when coming to the needle tip, needles can taper into a point, or you can have a conventional cutting where the cutting is on the external surface in a triangular form. And in a reverse cutting, the inner surface will be cutting. In both the reverse cutting and conventional cutting needles, only 1/3 till 1/3 will be the cutting edge, and the rest of the needle will be oval in shape. That is what is depicted here. Only the point will have a particular pattern of cutting, and the rest of the needle will be in oval shape. And again, you can see where all these needles are commonly used. Conventional or reverse cutting is what we commonly use for oral cavity or face wounds. The tips are tapered or reverse cutting, and cutting needles are easy to, with cutting needles, we can easily penetrate the tissues. But you have to be very careful, because if you kind of, what do you say, it is easier to cut through lateral tissues if you're not very careful with cutting needles. And then few terms which you need to be familiar with. Angle of needle fill, the extent to which you can deform a needle are determined by this angle of needle or bending moments, and the needle should be ductile enough.
Thank you for covering that so extensively, ma'am. The next question is the different types of wound dressings that are used in OMFS.
After suturing comes the dressings. The break in the continuity of the tissue should be protected with the dressing after suturing. The dressing should be to provide a coverage. It provides adequate pressure on the wound to prevent hematoma formation, and it may even give temporary support to the suture tissues. And when the dressing is moist, it is known to promote healing. Yeah, sorry for that small font size. but I had to put this in. We know Tegaderm. It is a semi-permeable, thin, adhesive, transparent dressings where you can use it, where exudates are minimum, and it is very traumatic, but it is very traumatic to remove. When you come to Gelonet, these are paraffin-based nets, Gelonets or Tully dressings, which are used in covering a wider areas of abrasions or burns. Then Hyperfix take the shape of the tissue to which it is covered and gives support to the tissue. And then our micropore, which is used on sutured wounds, dry sutured wounds. So where all you use what is given beautifully in this chart. The
Ma'am, I think your screen is frozen again. Hello.
Lata ma'am, are you there, ma'am? Lata ma'am, are you there?
yeah, I'm here. Can you hear me?
We're able
Yes.
to see the screen. Yes, ma'am.
Yeah. Okay. So in the abrasions, we use Tully dressings. But in lacerations, it can be left either open or dry, and you can use paper tape support for the wound. So oral wound, we have seen Surgicel. And whitehead varnish, the composition is given here. It prevents the oozing, gives postoperative pain relief, and supports the tissue to which it is applied. The indications will be especially in orbital flow reconstruction. It gives support for the orbital flow if you pack it onto the maxillary sinus. Carnoy solution, we know it's used in OKC solution, but that also was used as a dressing material once upon a time. Then bismuth iodoform paraffin paste is another one which is commonly used. It gives support for fractures, and it is a packing material for ENT surgeries and in tooth sockets maybe. Because of the iodoform content, it has an antimicrobial property. Zinc oxide base, we are very familiar with this. We all give zinc oxide based packs for our periodontal surgeries or in dry sockets. Then Alvogel, again a newer product which has come into the management of alveolar osteitis. It contains a local anesthetic agent with eugenol and iodoform.
Thank you, ma'am. So the next question is the updated guidelines in the management of a needle stick injury.
Coming to needle stick injury, we are all prone for injuries with sharps. We use a lot of sharps in our surgeries. And the evaluation after sharp injury starts from the very beginning. You have to have an idea of the tetanus vaccination status of the person who got the prick. And how do you assess whether the exposure was significant or not? Exposure to these body fluids will be considered as a high risk category, whereas exposure to tears, sweat, urine, feces, saliva, etc. will be less riskier unless it is contaminated with blood. And if the exposure happens to open wound or mucosa, that is more riskier than an exposure on intact skin. So I assume that it's very clear. Open wound or mucosal exposure is more dangerous than exposure to intact skin. All India Institute has come out with the guidelines. Immediately wash with soap and running water the area of exposure. And if it is on the mucosa, wash thoroughly. If it's an HIV, just like I said, wash the area, and you have to report to your superior and the casualty medical officer and infectious control disease. And the decision about post-exposure prophylaxis depends on the amount of exposure. You have to get serology for both the person and for the source person, that is the patient, and for the exposed person. And the results may be delayed, but you start with your post-exposure prophylaxis immediately. The best results will be within 2 hours. The long-term follow-ups are needed because about 50 to 70% individual may show zero conversion in 3 to 6 weeks after exposure. So it is better to advise an exposed person to use precautions for at least for 6 to 12 weeks, unless he is proved negative at the end of 6 to 12 weeks. Laboratory follow-up is very important. Immediately post-exposure, you should have a serology test, and then at the end of 3 months, and then at the end of 6 months. If at the end of 6 months the result is negative, no further testing is recommended. CDC also gives some protocols. Again, they start with the exposure risk. It's like if the exposure is none, there is no risk. If it is minimal, if it is more, if it is to an open wound, if it is through a percutaneous tract or with a large bore needle, then all these are considered riskier. If the patient is positive, if the patient is negative, no prophylaxis required. If the patient is positive, again calculate the viral titer in him. But the patient is unknown, or we are not able to trace the patient.
Ma'am, are you still with us? Lata, ma'am?
I think network problems.
Network problems, yeah.
I think even the last 2 slides haven't moved ahead.
Yeah, exactly. Yeah.
Yes.
True. Check with ma'am.
I think if either one of you can share the screen, I think.
Yes, so but ma'am needs to stop sharing the screen.
I will stop that, yeah.
Hello, can you see my screen?
Yes, ma'am. We can now.
Yeah.
Ma'am, if you could.
That's just 2 minutes. I don't know much about BUS.
Ma'am, actually, we lost you at the hepatitis slide.
Okay. Should I go back?
Yes, ma'am, if it's all right with you.
Yeah, I don't have an issue. Yeah.
Okay.
Is it okay?
A little behind this.
Little
One slide, I
behind.
guess.
Yeah. This is the post-exposure prophylaxis for the AIDS. We have 3 tablets which needs to be combined into a single pill. It is always usually available as a single pill. And first dose should be taken as soon as possible. Don't wait for the serology results to come in. And the second dose will be at the bedtime, 2 to 3 hours after dinner, because it kind of interferes with your food intake. When the results come, and if the results come as negative for the patient from whom you got the exposure, then you may consider discontinuing the tablets. So for hepatitis B, if the person who is exposed is already vaccinated and has adequate level of anti-HBs AG level, then there is no need for any further medication, but he has to be kept under follow-up. But if the post-vaccination titer is low, then he should be given hepatitis B immunoglobulin. And if the patient has been discharged and not available for testing, always consider the exposed person at risk, especially if there are certain risk factors in the patient. So like he is a drug abuser or is a high-risk category patient, etc. When the patient, when the exposed person is not protected with vaccination, you have to give immunoglobulin immediately and start the active immunization 14 days later. Is that clear? Hello?
Yes, ma'am.
Yeah. So the next.
Ma'am, so in this case, just a moment.
Yeah.
So in this case, you would recommend that all of the healthcare workers get their vaccination when they start,
Each
right?
of the person is strongly recommended to get the vaccination in healthcare profession. Yeah, that is a must.
Correct.
Yeah.
Noted, ma'am.
Yeah. going to the last question.
Yes, ma'am. So the last question is on the different types of burrs and their uses in maxillofacial
surgery. That took me back to my operative dentistry textbooks, and thanks, Ritvi, for the your contribution to my presentation. The anatomy of the burr, we all know it has a shank which is fits into the micromotor handpiece. The burr has a neck onto which the cutting end is attached. That is called the head. Different types of burrs are there, and we commonly use tungsten carbide burr for maxillofacial surgery. The different shapes, the round burrs and the straight fissure burrs are the ones which we commonly use. And the numbering system, 701, 702, and 703 in the straight fissure is what usually used. And it usually used with a straight handpiece under constant irrigation to remove the bone debris, to prevent clogging of the burrs, and to prevent overheating of the bone. And one thing which I would like to take you is this is the cutting edge of the cross section of the cutting part of the burr. It has a face which cuts and a back which supports the face. So when the face is wider, you can say this is wider. It is called a negative rake angle because the cutting face is behind the radial line. This is from the center to the tip of the cutting edge is the radial line. If the face is behind it, this is a negative rake angle. I don't know whether you can make out. So the tungsten carbide burrs have 6 blades, 1, 2, 3, 4, 5, 6, and negative rake angles on the face. So it protects the tungsten carbide burrs. It has longer life because it is broad enough to protect. And this area is where the bone chips collect, and the burr tends to clog between the back of a cutting edge and the face of a second edge. So this is the area where the bone chips clog. You have to have a constant irrigation. That is it. Thank you.
Thank you so much, ma'am. Thank you so much for clarifying all the doubts so eloquently. I doubt there'll be a lot of questions regarding this, but we're expecting the questions to be taken up and replied through email.
Yeah, Dr. Ritvi, we can now move on to the next session.
Yes, ma'am.
Yeah.
Ma'am, if you could just stop sharing.
Yeah,
okay, ma'am. Yes, thank you.
Yeah.
Ma'am, is the screen visible?
Yes.
Okay, so we'll move on to our next session for the day, which is on minor oral surgery. And the speaker is Dr. Ashok Ramadurai. Dr. Ashok is a fellow of the Royal College of Surgeons, Edinburgh, Ireland, as well as Glasgow. He has previously held a post of a senior registrar in the Singapore Health Services. He is also an examiner at the Royal College of Physicians and Surgeons of Glasgow, and Sir is presently working as a professor in the Department of Oral and Maxillofacial Surgery at Sri Balaji Dental College, Chennai. We welcome you, sir, and look forward to your talk.
Good evening, ladies and gentlemen. Can you hear me?
Yes, sir, you're audible, sir.
Professor Jimson, my current dean, my dear dental students from Sri Balaji Dental College, Thai Mugamia Dental College, and everyone, a very warm welcome. Now, I'm going to talk about routine oral surgery. I think I'll probably change it to routine oral surgery rather than minor oral surgery. Nothing's minor about the routine work which we do. It's dental-alveolar surgery. Yeah, we can take the questions now.
Sure. So the first question for the day is describe the management of a root tip displaced into the maxillary sinus.
Next slide, please. Okay, it's happened to me twice in my 20 years where I actually had to go and remove a root from the sinus, and both of them were iatrogenic, introduced by me. And so it's very often the palatal root of your upper sixes, and it's usually inadvertent displacement by the oral surgeon or the dental surgeon. Very often it's wrong technique and wrong instrumentation. At least in my case, one of them overzealously, maybe 20 years back, used a Kublan elevator to remove a palatal root, and it went flying in. And it was very unfortunate for the patient because he was actually a patient of nasopharyngeal carcinoma waiting to go for radiotherapy. So I had to close the flap and delayed the treatment by about 10 days. So my advice to you is, if it is only a root tip, leave it in situ. If you wish, do a radiograph. Don't be overzealous and push it into the sinus. It's after all a root. It's not a tumor which you're leaving behind. So you can document it in your notes, inform the patient, and take an appropriate radiograph to document it and follow it up. A lot of times it gets resolved or it just does nothing. Next, please. Now, this is a patient, interestingly, was a prisoner in one of the countries I worked in the health service. So the prison dentist attempted extraction and probably followed my technique and pushed it into the sinus. So it took a few weeks for the prisoner to actually come to the specialist on duty. So what I did was, I just went through the socket, and we did a intraoral periapical radiograph, localized it, and retrieved it. Next slide, please. So that's the root fragment, and it was quite easy because fortunately it did not travel much inside the palatal and the maxilla. It was just in the apices of the socket, so it was actually very easy to remove. Next, please. So we just closed it with a buccal advancement flap and followed him up. Next, please. So management, one is to localize the position of the root. You can do your routine RVGs, OPGs, and intraoral periapical radiographs. And CBC, if it's going to be, if it's taken a little bit of time or a few weeks before, it's very likely that it is displaced elsewhere in the sinus. So a CBCT will let you know the exact position. Usually fresh extraction, as I told you, because of the position of the apical bone and the maxillary sinus lining is usually in the apex. Longer duration, in my experience, I've seen it's traveled palatally. And the standard of care today is a CBCT. Most institutions and a lot of private practices do have a CBCT. It's the standard of care, and it will tell you exactly where it is. Next, please.
So just a quick question here. Do you see a lot of cases where you kind of lose the root in the tissue, especially when a flap is raised?
Lose it in the tissue, meaning?
Lose the root tip inside the soft tissues surrounding the space. Does that happen very frequently?
I did once push an upper third molar when I was training.
Okay.
But I've done every possible complication and I've learned from it. I've never experienced this.
Okay.
I've taken out 3 roots, 2 were pushed by me. So the third one was by the prison dentist.
Okay.
Next, please. What is the surgical management? Don't panic. If you've done it, don't panic. Remember me, don't panic. Adjust your light, good suction, take a mental suction, and it's usually helpful to break a needle, one of your LA needles, wide bore needle, attach it to the fine suction tip 4 or 5 and have a good look to localize it. If you're lucky, in the days of the old, when I was training, I know some oral surgeons did the Valsalva method where they would actually occlude their nostril and breathe through the nose and blow it. And if you're lucky, it'll fly out. So I wouldn't recommend that, but from training, from exam point of view, this was a question I was asked when I was a finally obedience student. So from examination point of view, you can make note of that. Surgical exploration in the apex of the socket will usually fish out the root. And if it's of a longer duration, please remember that there is a risk of sinus being infected with purulent, with pus. So a lot of times you need to do an antral lavage, a sinus lavage. And the trainees must be taught how to do it. And the way you do it is have a 50 ml syringe of warm saline, and then hold the kidney tray, if this is my case, just hold the kidney tray below the nose, and the patient must actually bend forward in the chair, bend down and hold the kidney tray below the nose. And then you irrigate with warm saline. Do it a few times till you get clear return. So what we normally do is, if there is pus in the sinus, we take a swab and send it for MCS, microbiological concern sensitivity. And then we do a sinus lavage and start with empirical antibiotics, usually Augmentin, and repeat the antral lavage every day or every other day till you get clear returns. And then you can successfully close the oroantral communication, which you've created by displacement of the root. Very often people do a mistake of closing an infected sinus and you end up with wound breakdown. So what you need to remember as a trainee is, well, if you can actually see the root, go ahead and fish it out, but do not close your oroantral communication if there is active purulent discharge or if there is evidence of sinusitis with pus in it. You need to do an antral lavage, and the way to do it is warm saline. All you need is a kidney tray. Bend the patient forward as much as you can. Keep the kidney tray below the nose. It's absolutely yucky, all the muck coming out through the nose. Do it a few times till you actually get a clear return. And then you can wait for 3 or 4 days. So you actually even get the class of antibiotic, which is sensitive. And sometimes you may need to change the class of antibiotic if it comes back as resistant, and then you close the flap. And that is probably the safest way to do it. So one is through the apex, and the other one, if it's a bit palatal and you want much more access, all you do is a Calwell luck. It's nothing but just a window created in the anterior wall of the maxilla, and then you fish out the root with a small artery or a mosquito. And these days, you can even see implants being pushed inside the sinus because of overzealous implant placement by young dentists. Next, please.
Thank you, sir. The next question is, are there absolute and relative contraindications for extractions?
Now, what I've shared is my experience. I'm not quoting any textbook, but this is what I've learned in the last 20 years. Now, my absolute contraindication, I'm not quoting any book, is recent MI. I've had patients, in the ICU with toothache when I was working in a hospital setup, and always the cardiologists were very fussed about recent MI and recent stent or a recent CVA. What happened to the screen?
No, I'm sorry, sir. Just one moment. Yes, sir, we're back.
Yeah. Recent CVA or recent MI has a high incidence of reinfarct. So it's not a bad idea to actually wait for 3 months. And worst scenario, if a tooth needs to be removed, you can always do a pulpectomy with plain lignocaine, or I use 1 in 200,000 LA. Remove the pulp, just put some calcium hydroxide and postpone the extraction. So a recent MI or a recent CVA, in my opinion, is an absolute contraindication for extraction because of the risk of a reinfarct. Now, in the days of the old, we were taught something called hemangioma of the mandible, and that's absolutely rubbish. Hemangioma is a solid endothelial tumor. What we were taught currently is classified as AV malformations, which can be high flow, medium flow, or low flow lesions. So certainly, if you see a multilocular lesion in the jaw with a tooth and you want to do a biopsy or remove something, for God's sake, stick in a needle, put in a needle and check whether there's whether you have a flow back of blood before you do any biopsy. So AV malformation is another absolute contraindications for oral surgical procedures like an extraction. My third absolute contraindication is Graves' disease or thyrotoxicosis, which is uncontrolled hyperthyroidism, where the patient has all signs and symptoms of thyrotoxicosis. Can you go back, please? And what are they? Sweaty palms, fine tremors, and a heart rate of over 100, and exophthalmos. So these are the signs of thyrotoxicosis. So if the patient is clinically euthyroid, then you can go ahead. But if the patient is not clinically euthyroid and has symptoms of thyrotoxicosis and uncontrolled disease, any stress or even a 1 in 200,000 of adrenaline can cause rhythm disturbance of the heart, and you can end up with atrial fibrillation and other arrhythmias. So, thyrotoxicosis, in my opinion, is an absolute no-no for dental procedures, especially extraction. This is what I learned from the endocrinologist when I worked in a hospital setup. So I've not taken it from textbooks. Most of the presentation is my own personal experience. Next, please. Relative contraindications, I mean, you can just go on and on, hypertension, diabetes, liver disease, renal problems, hemophilia, pregnancy. Certainly, last trimester is not a contraindication for extraction. I remember doing a wisdom tooth surgery for a lady who's for an expecting mother, and she did not turn up for suture removal, and the third day she actually happily delivered. So it's actually not a contraindication. Well, because of medical legal reasons, you can get a clearance or inform the obstetrician in charge and liaise with them. But in my opinion, it's not a contraindication for removal of tooth. Now, hypertensive crisis is something which you watch out for, and that's defined as a systole of over 180 and a diastolic of over 120. So in an uncontrolled, if you have a patient with uncontrolled hypertension and you need to do a procedure, what I do is I admit them in a hospital and I have an anesthetist on board, and I do it with sedation and monitoring, with midazolam sedation and some antihypertensive drugs under monitoring. And we can, yes, the cost is there. It'll cost you 12,000 rupees more for the anesthetic charge and the theater charge, but it is quite safe to do for patients with uncontrolled systemic diseases. And again, the American Heart Association for diabetes recommends 250, anything below 250 you can remove. I mean, there is no cut figure, it's all case by case. Sometimes if you have a septic tooth which is causing a potential space infection, and if the sugar is even 385, you need to go and remove it, because the treatment of choice in a space infection is removal of the offending tooth, and it's not establishing a drainage. So you can go up to in my opinion, I would be happy to remove any tooth for extraction for about 210 or 220, but I would usually cover them with preoperative augmentin, 1 dose before, followed by postoperative doses for about 3 to 5 days. What is the risk of uncontrolled glucose is? Basically, there is always a risk of postoperative infection because of dysfunctional neutrophil, and phagocytosis is not proper. The risk of secondary infection, and there is also a risk of osteomyelitis. Next slide, please.
Thank you, sir. Our next question is the description of the lingual split bone technique for the surgical removal of mandibular third molars.
Now, in my 20 years, I've worked with several surgeons in 3 countries, and there was only one surgeon who always did lingual split technique under general anesthesia in his list, and he was from Scotland, and he obviously did it for his private patients. So for the NHS patients, they had it, but he did it because he was very good at it, and it was very quick, because he believed there was hardly any postoperative pain, and it was very fast. It was all a quick GA. Is rarely practiced in current in the current scenario, because you can't take a chisel, mallet, and hammer patients. I mean, these days for oral surgical patients, you need to cajole them and pamper them and give them the best care, with minimal, dental alveolar surgery is a very cute surgery where you do a quick job, there's minimal morbidity, minimal swelling, and patient resumes function. So this is more for theoretical knowledge for the residents who are appearing for exams. I don't think anybody in this world actually practices lingual, lingual split technique routinely, especially as an outpatient local anesthetic procedure. Well, the technique is whatever type of incision you want to do. I usually do an envelope flap. Obviously, it's a full thickness mucoperiosteal flap. You expose the impacted tooth. The first cut you do is actually a vertical stop cut with a 3 mm chisel, which is usually done distal to the second molar. So that prevents the cut from propagating more anteriorly. Then you turn the bevel of the needle, bevel of the chisel, and then you do a parallel cut, which is the horizontal stop cut parallel to the cervix of the tooth. Next, please. And the third one is called the distal lingual split, which is done with a 5 mm chisel. Usually you keep it parallel to the external oblique ridge. And the whole idea is to remove, you expand the space, expand the socket, and you actually fracture the lingual plate, and you remove the horizontally impacted tooth or the distoangular in toto, rather than division of tooth and taking them in pieces with a burr. So it's essentially the tooth is removed in toto. Next one, please. So this was described in the days of the old, before I think rotary motors and burrs were invented by a gentleman called William Fry in 1930s. As I reiterated, as I already said before, the distolingual bone, you keep it at 45-degree angulation and parallel to the external oblique ridge. Next one, please. And this was actually modified by Davis in 1983, where he did not elevate the lingual soft tissues and prevented separation of the lingual bone to the attached periosteum. The main advantage of Davis's modification, which I still don't understand 100%, is prevent lingual bone loss and lingual nerve damage. So with this lingual split technique, there is 100% chance that you may actually damage the lingual nerve if you do not know what you're doing. So this happened to me the first time I did, and unfortunately the patient was a pharmacist, and it was my early days of training, and I apologize, and I really regret having done that. That was the first and last ever time I did a lingual split osteotomy for a tooth. So just because of reading textbooks and watching people, don't do it at home. Don't attempt doing this. This is a very technique sensitive method, and there is a very high chance of lingual nerve damage. Next, please. Now, a little bit of history is at 1993 introduced by William, and then published by Terence Ward in 56, modified by Davis. And interestingly, our own homegrown Professor Annamalai Thangavelu, who was my teacher, revisited this technique in Annamalai University, in Rajamati Dental College and hospitals during COVID. He was quite smart, and he actually used it in COVID as the best alternative option for bone guttering during COVID era, because to prevent aerosol, he actually published a paper he said it was suitable for young adults in elastic bone. And he also had a very low incidence of lingual nerve damage. Next, please.
Thank you, sir. The next question is on the relationship of the lingual nerve to the lingual cortex in mandibular third molars and the surgical implications for the same.
Now, this self-explanatory diagram was drafted and copied by Dr. Rithi. Thank you very much for the same. It's just self-explanatory. The lingual nerve is anywhere between 3.5 and around 3 millimeters from the lingual bone. And the depth again is anywhere between 2 millimeters to 8.5 and around 8 millimeters from the lingual cortex, from the crest of the lingual cortex. Now, what does it signify? Dear residents, before you make your relieving incision, please, for God's sake, palpate the internal oblique ridge, always, always. palpate the internal oblique ridge. Then with your index finger, palpate the external oblique ridge and make your incision always buckle on the external oblique ridge. Okay. The very common mistake which I see with residents is in the exam because of stress or during routine outpatient time because of in a hurry to finish, they don't take enough care, and I find a lot of their incisions going lingual, towards the palate, and there's always a risk of cutting the lingual nerve. So the take-home message from this slide is always remember that you can, by doing the relieving incision, there is a high chance that you may actually inadvertently injure the lingual nerve because of the proximity, as you can see in the slide. So palpate the external oblique ridge and the internal oblique ridge and make your relieving incision, say 1 or 1.5 distal to the impacted third molar, buccally along the external oblique ridge. So palpate the internal oblique ridge. Next slide, please. Now, this is important for our MDS residents to actually note the incidence of lingual and inferior alveolar nerve injury. Now, every day of the week, the only procedure we actually do is dentalveolar surgeries, third molar. And shockingly, when you ask them the incidence in the exam, they just go blank. So for God's sake, take a pen and paper and write it down. So from several different prospective cohort studies in English literature, inferior alveolar nerve, the incidence is about 0.6 to 6%, and lingual nerve is 0.7 to 11.5%. And after 6 months, which is considered a permanent injury, the incidence of inferior alveolar nerve injury is 0.9%, and for lingual is 0.2%. So if you were to tell your patient, you can tell them, I mean, the other ones by Gullicher and Badene are 3.6 and 2% and 3.9 and 2.6%. So if a patient actually asks you and tell them what is the incidence of inferior alveolar nerve injury, you can say from literature, it's about 3 to 3.5% for temporary numbness for inferior alveolar nerve, and permanent numbness for inferior alveolar nerve is less than 1%. And for lingual is slightly higher for the temporary, it's over 2%, and the permanent injury is 0.2%. So dear residents, please make a note of this for you to quote. Next, please. When I was a senior registrar in one of the health services, I actually did a 2-year study. It took me 2 years because I got a time off only half a day every week. So I actually did a retrospective study from the operating notes, and I looked at 1276 sites. Okay, some are bilateral, a lot of them are unilateral. So 1276 sites, and 8 of the 1,276 wisdom teeth excision had altered sensation. So that is 0.6% of inferior alveolar nerve, and only 1%, one patient of the 1,276 patients had altered sensation the first week post-off. So I published and I concluded that in my study, the incidence of inferior alveolar nerve injury was much lower, 0.6%, and lingual nerve was 0.08. And there we used only burr, and we always, did transverse or longitudinal section of the teeth. And very rarely we take it out in toto unless it's straightforward vertical. And we did not ever raise a lingual flap. We never ever used a lingual retractor. And all of them had an OPG with preoperative assessment. And the 1,276 wisdom teeth was done by the entire hierarchy. I mean, I included all of them from the junior most resident to the senior most consultant. And out of the 8, in fact, the consultants had more incidents, and that was purely because they attempted the difficult teeth. Next one, please. Now, nerve protection, I would never, ever recommend lingual nerve retraction because it's not really all, you can safely take out. In 20 years I've been doing, I've never, ever retracted the lingual tissues. In fact, what I would do is to dissect the distal and see the complete width of the mesiodistal width of the impacted tooth. That's very, very important. So after you raise your flap, the external oblique ridge, you just raise it a little bit till the internal oblique ridge, and you see the entire depth, the entire width of the mesiodistal width of the impacted tooth. And then you start guttering the distal lingual corner. And again, when you gutter, my dear residents, use a HP6 round burr. Don't use a Fisher burr, because a round burr removes only cortex, okay? And the motion should be from lingual to buccal, not the other way. So from lingual to buccal. And for bone guttering, I always use a HP6 burr. And for division, I use a 703 or 702 burr. Now, dental-alveolar surgery is a very cute surgery, and it's essentially a cortical surgery where you should not enter the cancellous bone. And if it's done well, the patient has very, very minimal morbidity. And it is something only maxillofacial surgeons like us can do. No plastic, no ENT can take out a disto-angular with trismus. So it is our forte. And only if you respect this and do it well, will you have a say in the society. Next, please.
So the next question is on the prevention and management of maxillary tuberosity fracture during removal of maxillary third molars.
Next slide, please. So a lot of times elderly people come for removal of non-functional upper eighths. And before you remove the teeth, always look at the distal bone. If there is a lot of distal bone in the OPG, then there is a risk of fracture of the distal bone fragment distal to the existing third molar. So what you need to do is you actually raise a palatal flap, raise it well, and raise a labial a buccal flap, and try and luxate the tooth. And once you luxate, in my experience, you should try and remove it with the forceps rather than criers, because the criers can be sometimes very violent. You end up with palatal mucosal tear and fracture of the tuberosity. So the prevention is first identify and take it out only if it's really indicated, and look for the distal bone, distal to the third molar. And if there's a lot of bone, just be prepared that something's going to break. And way you avoid it is raise a good palatal flap and luxate it and try and remove it with the forceps. When you support the alveolus with the forceps and try and extract the tooth may break, but never the tuberosity. Remember that. And all of us know the complications: fistula formation, denture instability, bleeding, secondary infection. And if you create an oronasal communication, there's always risk of sequelae of OAP, sinus infection and nasal regurgitation. Next one, please. So we've been through this. Next one, please. And, lastly, you need to prescribe them with, if at all you're going to, closing with a buccal advancement flap with or without fat, you give them antibiotics, nasal decongestants, and analgesics. So we call it the antral regime, and not blow the nose. They can sniff as much as they want. That is fine, but do not blow a nose. And if they want to sneeze, don't hold the sneeze and sneeze like a buffalo, just let go. And there used to be a debate of air travel following oral fistula communication. 20 years back, in fact, I remember canceling somebody's holiday because I closed the oral fistula because of the decompression effect. But nowadays, flights are very, very compatible. And even if somebody has a sinus procedure, like an oral fistula closure, you can comfortably fly even the following day. Next slide, please.
We'll quickly move on to the next question, sir. It's the post-operative extraction instructions and the reasons behind each of those instructions.
I'm not going to go through all the instructions, but I've just selected a couple, which is very relevant, and a lot of residents do not know. Why do you instruct the patient to bite on the gauze for 30 to 45 minutes? Now, there are two systems which you must understand. One is the clotting mechanism. The other one is the fibrinolytic system, which removes the clot. Okay, like you have an inlet power supply and a drainage at any home. So after clotting, what happens is your clot retraction. Okay, clot retraction is a process which starts in about 20 minutes and it actually proceeds to about 4 hours. So during clot retraction, the serum is expressed and all the clotting factors have been used. So that's the difference between plasma and serum. So the clot actually starts contracting and retracting. Now, once the clot retraction has started, then the clot is stabilized. And that is the reason why we tell our patients to bite on gauze for about 30 to 45 minutes. Next slide, please. So it starts at 30 minutes, proceeds to 4 hours. Platelets are necessary, and any thrombocytopenia or any problems with platelets, the clot retraction doesn't happen. And during the clot retractions, platelets get attached to the fibrin fibers and they get entrapped in the clot. And they continue to release more fibrin stabilizing factor, which is a procoagulant, and there is more cross-linking of fibers. And what is the whole objective of clot retraction is to get the edges of the broken vessel together and increases the hemostasis. So the main reason why we ask our patients to bite firm, bite hard on gauze, not to chew on it, bite firm with pressure, is what the phrase I tell the patients for 30 to 45 minutes is clot retraction starts at 30 to 45 minutes. By 45 minutes, it is almost stabilized, it is established. That time the clot will stay in the mouth and you can take out the gauze and throw it into the dustbin. Next, please. Well, you have other instructions: soft diet, adhere to medicines, put ice pack. I usually tell my patients put ice pack outside, to prevent swelling. Put it for 3 minutes every half an hour for the next 48 hours. But ice pack has no value after 48 hours. For the next 24 to 48 hours, you can keep them. I just said 3 minutes because after that it gets more difficult. It gets painful. So you can either give them 4 pieces of ice, or you can give them, they can use frozen peas or frozen vegetable from the freezer and put it as an ice pack, which I've not included. And how about smoking? Yes, there is an article published saying that smoking actually causes increase in swelling. Okay, so smoking causes increases in swelling, but obviously it interferes with the inflammatory process. So if you're going to blow nicotine into the sterile area, then the patient has to pay for it. Procedures like delayed healing, like a dry socket, secondary infection, and risk of bleeding. Alcohol, there is a saying that alcohol interacts with antibiotics, and it's debatable, but it's sensible to stay off alcohol. Next, please.
Our last question for the day, sir. The localization of an impacted maxillary canine.
Okay, now I've answered this from a surgeon's perspective. Now, I prefer the term ectopic canines rather than an impacted canine. For the surgeon, only this matters. We need to know the position of your ectopic canine. Is the canine labial, is it palatal, or interarch? Now, open the mouth and have a look. If it's obviously labial staring at you, it's labial. If you have a palatal bulge, it's palatal. If there is no bulge, then you know it's interarch. It can't be anywhere else. So there are only 3 positions: labial, palatal, or interarch. So by looking at it, you've got almost 90% of the answer. And usually labial impacted canines would actually tip, if it's just above the lateral incisor, it will tip the root of the lateral incisor. So you would find that the lateral incisor is not at level of the central, it's slightly forward, it's tipped up. So tipping happens, and that will give you actually a clue about a labially impacted canine. And why else is it important? It is important because you need to plan your access. So is it a labial approach or a buccal approach or a palatal approach? If it's interarch, then you probably need to open both sides of the flap, but usually it is just one side. And I would prefer, if you're in doubt, I would definitely open a labial one. It's easier to do rather than a palatal one. Next slide, please. Now, just routine things, OPG. Now, this young lady who's my daughter actually had bilateral impacted canines. So one of them, both of them are quite high and both of them are labial. Next one, please. So the other radiograph, which is quite useful, is a lateral cephalogram. A lateral cephalogram will obviously tell you the position of your ectopic canine. Is the cusp palatal to the central incisor, or is it interarch, or is it labial? So these two X-rays can actually give you a clue on the position. Next one, please. Certainly an intraoral periapical X-ray, and if you can use a rule of slob, I mean, nobody does that because of the advent of CBCT today. Next one, please. Yeah, these are the RVGs done in the practice to find out. Now, you have 3D reconstruction images, and you have coronal views and axial views, so you can actually localize and find out the position of your impacted canine in relation to the palate and or the adjacent teeth. So the standard of care today is CBCT. I mean, it's available in almost all dental schools, and every postcode has at least 5 CBCT centers, and even small towns have a CBCT center, and it's only going to cost you maybe 1,500, and it is justifiable. It is not unnecessary radiation, and it is certainly mandatory that we get a basic CBCT only of the maxilla to assess the position of the impacted or the ectopic canine. Next one, please. It's a joint decision between the author. I don't want to go through this. Next one, please. Now, what are the options of management of an ectopic canine? One is orthodontic traction, where you expose and your orthodontist will bond a bracket or a gold chain. So it's bonded bracket. If it's an unfavorable position, then you need to excise the ectopic canine. So it must be a sound judgment based on clinical and radio diagnosis on the position of the tooth. Now, it's very, very important, especially when you're going for orthodontic treatment, for the patient and the parents and or the family to understand the complexity and the time taken, because usually a straight wire, orthodontic case we can usually finish it within 12 to 18 months, but with an ectopic canine, it can go over 24 months. So it's very, very important for the parents and the patient to be on the same page as the orthodontist and to understand the time taken, because and they must consent for it. And I always warn the patient, if you're going to excise an ectopic canine, you certainly need to warn the patient about the risk of damage to adjacent teeth. Because if it's going to be a difficult tooth, you may want to do a crown division and take out the crown and the root separately. There's always a risk of inadvertent injury to the roots of your adjacent teeth. So you'll devitalize them, so they may need root canal treatment. So it's important for you to warn the patient about pain, swelling, infection, blah, 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 plus the risk of damage to your adjacent teeth. They may discolor, they may warrant a root canal following a crown. If it's going to be orthodontic, you certainly need to warn them about the risk of resurgery. A lot of times the bond fails. Anything can fail, so the bond fails, and so you need to go and re-expose it and rebond it. And sometimes in the best of hands, surgery is not magic. You must understand that. You can do the same treatment for different people, and you can end up with slightly different results in a minority of patients. So you certainly need to warn them about failure of treatment. Next one, please. That's it. Thank you very much for your attention, ladies and gentlemen.
Yes. Thank you so much, sir. Thank you for all your added clinical tips. I'm sure all the questions have been clarified in detail. Thank you to Dr. Lata ma'am as well for that extensive clarification on all her questions. I think that wraps up our session for the day, sir.
Thank you, Dr. With this, we come to the end of the session. On behalf of Tamil Nadu AOMSI, we would like to extend our heartfelt gratitude to the mentors, Dr. Lata Rao and Dr. Ashok Ramaturai, and moderator, Dr. Ritvi Bagadia, for their valuable contribution and sharing the knowledge. Thank you, ma'am, sir, and Dr. Ritvi for the wonderful presentation. Thank you all.
Thank you.
Now, I request the participants to stay connected to complete the feedback form. The participants are requested to fill in the feedback form posted in the chat box. Filling up this is mandatory for your certificates. Please fill it within 10 minutes. Thank you all.
Can you make a note of the next presentation? It's on Friday at the same time, 8 o'clock.
It's a Friday, 8 o'clock, sir.
And the topics?
Topics are implantology and maxillary sinus and salivary glands.
Okay, so Friday, 8 o'clock, implantology and?
Maxillary sinus and salivary glands.
Yeah. It's again a very important topic.
May I take this opportunity to profusely thank Dr. Ritvi Bagadia for all your contribution. I mean, you did wonderful slides in a short time. I know you're doing a busy job. Thank you very much indeed. And Dr. Kalpa and Professor Jimson, thanks.
Thank you, sir.
Dr. Elevenel and everyone.
Thanks all. And like Dr. Ashok said, special thanks to Dr. Ritvi.
Thank you, ma'am. Thank you so much.
So we'll sign off, sir.
Yes, sir. You can say.
Yeah.
Thank you.
Thank you.
Thank
Dr.
you, sir.
Thank you.
Bye all.
Yeah. Thank you, Dr. Ritvi.
Thank you so much, Sir Jimson, sir, Elevenel ma'am, and Kalpa ma'am. Thank you. Thank you, Shashikala ma'am.
Thank you.
Thank you all. Meet you in the next session.
Is it time, Sashi? Can we wind up?
Yes, ma'am. It's 10 minutes.
Kalpa, can we wind up?
Yes, ma'am. Sure, ma'am.
Okay, then see you all. Bye-bye.
Yes.
Good night.
Bye, ma'am. Good night. Thank you.
Good
Thank
night,
you.
everyone.
Good night. Good night.